ST elevation myocardial infarction. Etiology, pathophysiology, or pathology. Rupture of an atheromatous plaque exposes the rich lipid core to the circulating platelets and fibrin, which forms thrombus, occluding the artery. Occlusion will lead to full-thickness muscle necrosis. Transient occlusion leads to limited heart muscle death. Epidemiology. Approximately 300,000 myocardial infarctions occur every year in the UK. 1/4 of patients do not reach hospital. Death rates are declining. Clinical presentation. Common. Rapid onset, severe and crushing central chest pain radiating to the jaw and left arm that is unrelieved by glyceryl trinitrate, GTN, or oxygen. Acute breathlessness, pulmonary edema. Cardiac arrest, ventricular fibrillation. Uncommon. Epigastric, arm, or back pain. Collapse. Vomiting and sweating without pain. Painless infarct, diabetics and the elderly. Physical signs. Common. Examination may be normal. Patients are pale, sweaty, and often appear to be in pain. The patient may be hypotensive or hypertensive. Listen for pulmonary edema. Uncommon. Epigastric tenderness. Investigations. ECG, ST segment elevation and new onset left bundle branch block are indications for reperfusion treatment, Fig 39. Biochemical markers. Cholesterol level may drop after 24 hours for up to 2 months. Echocardiogram, indicated in cardiogenic shock. Differential diagnosis. Unstable angina or non-ST elevation myocardial infarction. Thoracic aortic dissection. Musculoskeletal pain. Pain of gastric or esophageal origin. Treatment. Emergency. It is vital to start reperfusion treatment as soon as possible, either with thrombolysis or primary percutaneous coronary intervention, PPCI. NB. Indications for thrombolysis. ST segment elevation greater than 1 mm in the standard leads, greater than 2 mm in the chest leads or new bundle branch block. Typical chest pain within 12 hours of onset. Bundle branch block. If there are no old ECGs and there is a good history for a myocardial infarction, then the patient should be thrombolysed. Indications for PPCI. ST segment elevation greater than 1 mm in the standard leads, greater than 2 mm in the chest leads or new bundle branch block. Typical chest pain within 24 hours of onset. In the presence of cardiogenic shock, PPCI is more effective than thrombolysis. Take history whilst obtaining intravenous access. Simultaneous recording of ECG and observations by nursing staff. Oxygen, opiate analgesia, and antiemetic. Aspirin 300 mg if no contraindications. Clopidogrel 600 mg. Once ST segment elevation myocardial infarction, STEMI, is confirmed on ECG, quickly examine the patient and ensure there are no contraindications to thrombolysis and angiography and antiplatelet therapy. Transfer to coronary care unit after reperfusion initiated. Intravenous insulin for diabetics, or where blood glucose greater than 11 mol/L. See Fig 40. NB. Contraindications to thrombolysis. Consultant advice should be sought before deciding not to reperfuse a patient with STEMI, and PPCI should be considered. Prolonged resuscitation is not a contraindication unless there is obvious trauma. Oral consent to thrombolysis should be obtained from the patient, and the risk of hemorrhagic stroke should be explained. The following are considered contraindications to thrombolysis: active internal bleeding, active peptic ulcer, uncontrolled bleeding tendency, stroke in the last 6-12 months or any previous hemorrhagic stroke. Obtain neurosurgical advice in the case of clipped subarachnoid hemorrhage aneurysm. Aortic dissection. Uncontrolled BP greater than 180/110 mmHg, treat with intravenous GTN, then thrombolus. Major trauma or surgery within the past year. 90 minutes after thrombolysis the ECG should be recorded. If the ST segments do not show greater than 50% resolution, then rescue percutaneous coronary intervention may be appropriate. Obtain consultant advice. NB. Contraindications to PPCI. Consultant cardiologist advice should be sought prior to transfer to a catheter laboratory. Unable to take aspirin and clopidogrel. Severe peripheral vascular disease making femoral or radial catheterization impossible. Active bleeding, preventing administration of antiplatelet drugs. Thrombocytopenia. Allergy to iodine, contrast contains iodine. Inability to lie flat, intubation may be necessary if patient has resistant pulmonary edema. Patients who present within 2 hours of pain have similar outcomes with both treatments. Thereafter, morbidity and mortality are lower with PPCI compared with thrombolysis. Patients in cardiogenic shock are best treated by PPCI and may have an intra-aortic balloon pump inserted. Short term. Standard treatment should include the following: beta blocker, taken orally within 24 hours and continued indefinitely. An angiotensin converting enzyme, ACE, inhibitor is of particular benefit in patients with left ventricular, LV, impairment, but improves the prognosis of all patients. Statin, for all patients unless contraindicated. Sliding insulin scale for patients with blood sugar greater than 11 mol/L or known diabetics. Warfarin, indicated for patients with atrial fibrillation, severe LV dysfunction due to risk of LV thrombus, or who exhibit presence of LV thrombus, Fig. 41. Clopidogrel, given for up to 30 days after thrombolysis, or for up to 12 months after PPCI. Cardiac catheterization and revascularization is recommended for all patients within 24 hours of STEMI. Definite indications include recurrent pain, reinfarction or small biomarker rises suggesting little damage from the infarct. Long term. Continued secondary prevention is important. Glucose tolerance testing should be considered as a high proportion of patients have diabetes mellitus. 30% of these patients are missed when fasting glucose alone is tested. Complications. Common. Hemorrhage induced by thrombolysis, transfuse as required. Hemorrhage from arterial puncture site, apply direct pressure, transfuse as required. Ventricular fibrillation/tachycardia, cardiovert prompti. Atrial fibrillation. Complete heart block. Pulmonary edema. Cardiogenic shock, seek expert advice. Post-infarct unstable angina. Reinfarction. Post-infarct pericarditis, usually benign and responds to NSAIDs, echocardiogram is needed to exclude contained rupture. Stroke, urgent CT of head required. Deep vein thrombosis/pulmonary embolus. Uncommon. LV rupture, Fig 42. Ventricular septal defect. Severe mitral regurgitation from papillary muscle rupture or ischemia. Dressler's syndrome, fever, pleuropericarditis, anemia, raised erythrocyte sedimentation rate, usually 1-4 weeks after infarct. Prognosis. This is determined by LV function, comorbidity, and whether the patient has been revascularized. Stress testing identifies patients with ischemic myocardium who require cardiac catheterization and revascularization. Patients with poor LV function undergo repeat echocardiography at 6 weeks to see if remodeling has occurred. Of patients suffering STEMI, 25% treated conservatively develop unstable angina. 10% treated conservatively have a further infarct. 25% with a first myocardial infarction do not reach hospital alive. 10% die before discharge. 10% die in the year after discharge. Prevention. Primary. Prevention involves regular exercise, a healthy diet and stopping smoking. Secondary. Aspirin, beta blocker, ACE inhibitor, statin and clopidogrel. Patients with poor LV function, ejection fraction less than 35%, undergo repeat echocardiography at 6 weeks to see if remodeling has occurred. If LV function remains poor, an implantable cardioverter defibrillator may be indicated. Patients with poor LV function may be treated with spironolactone or eplerenone if creatinine less than 180 micromol/L. NB. Advice to patients. On admission, inform the patient that he or she is having a heart attack and that effective treatment is available. Advise that the risk of treatment is less than the risk of the heart attack. Caution that the main risk is of bleeding, and that thrombolysis carries the risk of stroke. On discharge, a good recovery is expected. Cardiac rehabilitation. Patients are seen prior to discharge by the specialist nurses. An exercise program is arranged and support to help them stop smoking is offered. Car drivers must cease driving for 4 weeks, and heavy goods drivers must inform the DVLA, Driver and Vehicle Licensing Agency, in the UK and must satisfy requirements prior to relicensing. The usual advice regarding fitness for sexual activity is that the patient should be able to climb 1 flight of stairs prior to intercourse. Smoking cessation is vital. It reduces risk of reinfarction by 50%. Always carry GTN, even if free of angina.